what's happened internationally and what's happened in Ireland, I think internationally we have developed hormonal therapies that are more effective. We've been able to predict which patients will benefit from hormonal therapies. We've developed in breast cancer specialized surgery. We've developed less surgery. We do an awful lot less mutilating surgery than we used to do. Radiotherapy is more precise and focused and less toxic. We see far fewer patients have problems with that, but really the advances have been in things like chemotherapy and in the targeted therapies against the HER2 positive breast cancers. The implications of this have been obvious. Internationally, death rates from breast cancer are falling. In Ireland, as well as all of that, we have gone from a situation where we had virtually no cancer specialists and very limited treatment of patients who'd had surgery for breast cancer to a situation where we have extensive treatment of patients. So not only have we better treatment, we're actually giving it to the patients. And every year in Ireland, we have more and more patients with breast cancer. I think when I started off here in Ireland back in the late 90s, we probably had about 2,000 new patients with breast cancer a year. We now have close to 3,000 new patients with breast cancer every year. So you can see the disease is more and more common. Despite all of that, the death rate has been falling by about 1.5% to 2% per year. And that's all because of better treatment given to patients. They're actually receiving their treatment in an organized fashion with better therapies. And the prognosis for a woman who's diagnosed with breast cancer in Ireland today, her chance of being alive in 20 years' time, is pretty much the same chance that her mother would have had of being alive in 5 years' time, if her mother was diagnosed 30 years ago. So that's kind of the extent of the improvement that we have seen. And that's due to better treatment given properly. I think the significance of Herceptin is that it has transformed the outlook for a group of patients who have breast cancer. About anything between 18 and, depends where you are, 18 and 25% of women with breast cancer have a breast cancer that's called HER2 positive. HER2 is a protein that's present in normal tissues, and these breast cancers have too much of it. It's a normal protein, it's not an abnormal protein, but there's way too much of it on these tumors, and it's like a little engine that's making the tumor grow. And in the old days before Herceptin, these patients had cancers that were aggressive. We knew that. We knew they relapsed early, we knew they relapsed more often, and we knew that the patients had a poor prognosis. What Herceptin does is Herceptin is an antibody. Now, your body makes antibodies when you get a viral infection, and these antibodies bind to the virus and they take it out of the system. What Herceptin does is it binds to the HER2 protein. So it's a bit like a little key that turns off the engine that's making these cells grow. And Herceptin given to patients who have advanced breast cancer, so breast cancer that has spread to some other part of the body, advanced breast cancer that's HER2 positive, has improved the survival for those patients very significantly. I mean, before Herceptin, maybe 5% of patients with advanced breast cancer that was HER2 positive would be alive 5 years after starting treatment. Now it's more like 20 to 25% of patients, so there's a substantial increase. In patients with early stage breast cancer who've just been diagnosed with breast cancer that's HER2 positive, if we add Herceptin into the patient's chemotherapy, we reduce the death rate by about 40%. I mean, that's a transformative event, really. I well remember the original studies that we did with our international collaborators here in Ireland in patients with HER2 positive breast cancer. It was such a terrifying disease that it was, patients were just totally on board for getting onto the study and being treated with Herceptin, and it has transformed the outlook for these patients. This target is clearly susceptible to a number of ways of dealing with it. Lapatinib is an oral agent, so obviously it's a little more convenient than an injection for patients. Lapatinib, even in patients who are resistant to Herceptin, can produce benefits compared to just chemotherapy alone. Interestingly, because it's an oral agent, let me go back on that. Because it's not an antibody, it has different effects, and it not only inhibits the HER2, but it also inhibits a thing called EGF, which is similar to HER2, which is very important for skin growth. So lapatinib can cause toxicities in the skin. You can have problems with your nails. You can have problems with the earrings, where there are little holes where the earrings go in. They can get inflamed. And patients can also have bowel problems because EGF, the epidermal growth factor, is very important in the normal processing of the bowel. So it has interesting side effects. It tends not to have the heart problems that Herceptin causes, but it can cause kind of irritating quality of life type side effects. Pertuzumab is another antibody. It's an antibody that targets a different part of the HER2, and it inhibits the activity of HER2 in a particular way, particularly its binding to other members of the EGF family. And when it combines with Herceptin in patients with advanced disease, it has profoundly beneficial effects. So I've already said that Herceptin transforms the outlook for patients with advanced breast cancer that's HER2 positive. Pertuzumab added into that produces even further benefits. So right now we're in Ireland participating in a study giving pertuzumab with Herceptin to patients with early stage breast cancer, which I firmly believe is going to have a very beneficial effect for those patients as well. And we would expect pertuzumab to be widely available probably within before the end of the year, hopefully, for patients with advanced breast cancer. And then the third compound is TDM1, which is Herceptin, but it's not just the antibody, it's the antibody with a chemotherapy molecule called maytansine attached to it. So you're actually giving the patient the antibody with the chemotherapy attached to it. Of course, the great thing about that is that's a real targeted treatment, because the antibody is only attaching to the HER2. So the chemotherapy drug is only getting to the cancer cell. And again, when we see patients who have quite resistant breast cancer, who've had lots of chemotherapy, lots of HER2 treatment, we find that TDM1 can induce responses with very limited side effects. So it promises to be another tremendous advantage. I think what the lesson here is that when we identify the target, when we identify the molecule that's really important, and HER2 is really important in these breast cancers, we're able to develop therapies that can deal with that can have a huge impact. Our problem is tumours in which we don't know what the target is, or we don't have one single target. I mean, HER2 is perhaps one of a small number of targets that are dominantly important in a common disease, and so therefore treatments are incredibly effective. It's the tumours where we don't have a dominant target that we have real trouble identifying a targeted treatment or a molecule that can really make a difference. Anti-estrogen therapies have made an enormous impact on the treatment of breast cancer. Anti-estrogen therapy for breast cancer has been around for over 100 years. In 1894, a surgeon in Glasgow called George Beatson removed the ovaries from 3 women who had advanced breast cancer, and 2 of them got considerably better. And that was the first ever hormonal therapy, the first ever targeted therapy for cancer, and it's over 100 years ago. And the first studies of hormone therapy given to women who just had surgery for breast cancer began in 1949. So, hormonal therapy for breast cancer has been around for a very long time. It's conclusively proven that hormonal therapy dramatically reduces the risk of recurrence for women who've had surgery for breast cancer, for those who have hormonally sensitive breast cancers, which is the majority. And more human lives have been saved by simple anti-hormonal treatments for women who've been diagnosed with breast cancer than all the human lives that have been saved by chemotherapy for leukemia and lymphoma and testis cancer, all these diseases that are very sensitive to chemotherapy. More people have been saved by things like tamoxifen than these other more aggressive therapies. And hormonal therapy has, also not only can it reduce the risk of recurrence dramatically for women who have been diagnosed with breast cancer and treated with it, but it can actually reduce the chance of getting breast cancer in populations who are at significant risk of developing breast cancer. So it's an incredibly important part of breast cancer treatment. Hormones play a huge role in the development of breast cancer. I would suspect that 200,000 years ago there was very little breast cancer. I think that women probably weighed a lot less. Their first period was probably much later in life. They probably, had a first child within a year of menstruating for the first time. They lactated. They did that repeatedly, probably for a number of years, and they probably didn't live much past 30. Women didn't get breast cancer. Men didn't get prostate cancer. Nowadays, we have the first period is much earlier in life, perhaps around 11 as opposed to 16, because women weigh more. They don't have a first child until they're 31 or 32, and that's important because the breast doesn't become fully mature until such time as lactation takes place, which could be in the early 30s. Women weigh more on into the menopause. They live much longer. They take exogenous estrogens, by which I mean birth control pills, hormone replacement therapy, and all these little things add up, and they all increase the risk of getting breast cancer. So breast cancer is very much a hormonal disease. Probably 75% of all breast cancers are clearly and obviously going to be susceptible to hormonal treatment, anti-hormonal treatment. So that's a lot of breast cancers.
This question of genes and, are you born with it? How big a factor is that, do you think, in the incidence of cancer?
Well, there are certainly a minority of patients with cancer who clearly have an inherited abnormality that causes that cancer. And we tend to see that because we see these cancers develop very early and very young. The classic example is retinoblastoma, which is an eye tumor, a very rare eye tumor that can be inherited and occur in some children. About 3% of breast cancer patients will have an abnormality of the BRCA gene, and those people are get very high risk for developing breast cancer. And then about maybe 4 to 5% of patients with colon cancer have a genetic abnormality that results in colon cancer at quite a young age as well. I mean, all cancer is genetic in that it's an abnormality of the gene that results in an abnormal protein or series of proteins that make for disordered growth. In some small numbers of people, those genes are inherited as abnormal, and that's the inherited cancer. But in most other patients who develop cancer, they're simply developing an abnormality of the gene that takes place as a result of exposure to alcohol or cigarette smoke or modern life or obesity, whatever way it works. So really all cancer is genetic. A minority of it is inherited, most of it is acquired over life. So that's where genes fit in to cancer. Now, I think, the human organism is phenomenally complicated and complex, and much of that comes from its genetic background. There are thousands, tens of thousands of genes in the system. They all produce proteins. Those proteins are modified. They all work in certain ways. It's an incredibly complicated system. But within the genome of all of us, there are genes that modify our cancer risk. We know an awful lot less about that. We know that these genes will increase one's risk of getting cancer to a modest extent, but don't make it absolutely necessary. I don't think we have much handle right now on how to interpret that information for patients, or how we might deal with that information for patients. I mean, to be sort of maybe a little facetious about it, there may well be people whose genetic environment, whose inherited genetic environment, means that they can smoke 40 cigarettes a day for 100 years and never get lung cancer. The Queen Mother comes to mind. We don't know enough about anyone's genome to be able to say that that is the case. But we will probably be able to say that in a relatively short period of time, to be able to say to an individual person at the age of whatever, maybe 18, as part of their 18th birthday present, they might have a genetic profile that says your risk of getting colon cancer is extremely low, so go off and eat all the sausages you like. Your risk of getting heart disease is very high. We're starting you on an anti-cholesterol drug tomorrow. We will be able to know an awful lot more about the genetic predisposition, which is not quite the same as having one of these abnormal genes, the low-hanging fruit you talked about earlier. So that's where genetics fits in. All cancer is genetics. Most of it is acquired. Some of it is inherited, and there is a genetic background that modifies your risk. The United States has the best survival rates for many of the common cancers, particularly, let's say, breast cancer and colon cancer, for instance. Our rates are not as good. I think that our rates are improving all the time, but the rates in the other countries are improving as well. We're getting close to average in Europe at the moment. We have a lot more to do. I think there's probably a number of issues related to that. I think our treatment for colorectal cancer, and I think our treatment for the common cancers, colorectal cancer, lung cancer, breast cancer, prostate cancer, is good. I think it's good. It's a lot better than it used to be. It's much more coordinated. Certainly with the 8 cancer centres, people are getting state-of-the-art care. I think if you look particularly at the States, where actually treatment is not as coordinated as it is here, they have better survival rates. And you have to ask yourselves, why is that? I think Americans present to their doctor much sooner than we do. I think they're more aware of the risks. I think they actually turn up quicker. We still have a problem, I think, in this country with patients coming to us very late. I still see breast cancers in this country that are fungating tumours like you think you might have seen back in the 30s and the 40s. We see that in this city right now.
What does that mean?
It means the tumour has been there for so long it's growing out through the skin.
Say 20 years from now, somebody goes to their doctor, they may have cancer. In what way will it be different to the way it is now?
I think we will be able to much better assess whether they have small amounts of disease that has travelled to some other parts of their body that we don't know about right now, but we suspect. I think we'll have blood tests that will be able to detect abnormalities in the blood that will tell us this patient has little bits of cancer or this patient doesn't. So I think we'll be much better at that. We'll have sort of very, very refined, very high granularity, as it were, diagnostics that will be able to tell us much more than we can nowadays. I think we will be looking at the individual tumour in the patient, look for its molecular abnormalities. What are the little engines that are making this tumour grow? And hopefully we'll have treatments that are able specifically to deal with that. I think over the last, 70 or 80 years, we have become trained to think of breast cancer as growing in the breast, bowel cancer growing in the bowel, lung cancer growing in the lungs. What we will see is probably the molecular footprint of each individual tumour, which will predict its treatment, which might not necessarily be the same, probably almost certainly won't be the same for all lung cancers or for all breast cancers. So I think we'll do an awful lot more molecular diagnostics, which we're only starting to do now. When Steve Jobs, who had unfortunately he had a rare tumour of the pancreas that spread to his liver and ultimately killed him, he had the entire genome of that tumour sequenced to look for mutations, abnormalities that might be suitable for treatment. I believe that cost $100,000 to do at the time he did it a few years ago. It now costs less than $3,000 to do that. So we'll be able to do all these tests to look in the individual tumour, to look right into its nucleus and say why it's growing. Our challenge, of course, is to be able to produce treatments that will target that particular abnormality. Some tumours will have one abnormality, and those are the ones where we have the low-hanging fruit you used earlier, the HER2 abnormality in breast cancer, the BCR-ABL abnormality in chronic myeloid leukemia. But other tumours will probably be much more difficult. And the classic example would be lung cancer, where you look at the genome of a lung cancer, the cell, it's got abnormalities all over the place from cigarette smoking. Picking an individual treatment to work in many of those is going to be more difficult. Having said that, we're already starting to see some lung cancers where there are individual abnormalities, where there's a particular type of treatment, the new drug crizotinib comes to mind, that has a profound effect on the disease. Interestingly, in the lung cancer patients, they tend to be the patients whose tumours have developed in non-smokers. So, there'll be subtleties to all of this.